risk smoldering multiple myeloma improves progression to delays the progression to multiple myeloma, also improves the overall survival. Thereafter, small single-arm trials with using Carfil Lendexa and Carfil Lendexa along with the daratumumab was done, but these are not the standard of care. But we had a good decent data from two trials showing the progression-free survival and the overall survival, the Len trial and the Lendexa trial. So this is from the article which was written in the recent American Journal of Hematology, which was published by Professor Vincent Rajkumar. So as of now, if you see a high risk smoldering multiple myeloma, so it is ideal always to use lenalidomide or lenalidomide plus dexamethasone for 2 years in these patients with high risk smoldering myeloma. All other patients, so either the low risk or intermediate risk smoldering multiple myeloma, should be observed without any therapy. So, because of this, if you are seeing any smoldering multiple myeloma in your clinic, you need to do fish, you need to thoroughly risk stratify them with the especially either with the fish based thing or by the 2 by 20 by 20 model. And all patients of high risk smoldering multiple myeloma should be receiving either lenalidomide or lenalidomide plus dexamethasone for a period of 2 years. So this is what has happened in the smoldering multiple myeloma. For MGUS, there is no treatment. You need to observe the patients over a period of time. If at all there is a myeloma defining event, you can treat them. Otherwise, all patients with MGUS will be observed till they have a myeloma defining event. Smoldering multiple myeloma, low risk, intermediate risk, you observe. High risk, you treat them with lenalidomide and lenalidomide plus dexamethasone. Coming to the multiple myeloma proper, so I will show you two cases which has the longest survival in my practice. So this was the case which was diagnosed in 2010, and this was the last line was started in 2023. And this is another case which was started in 2012, and the last line was started in 2023. So that means these are the patients who have a more than 10 to 12 years of survival. But what happens in myeloma usually in a clinic is multiple myeloma is a disorder, is a disease where remissions can happen with treatment. Soon, based upon their risk category, the relapses happen. They will again respond to the treatment, again relapses. So this is almost like a remitting, relapsing type of disease. So this is the natural course. When a newly diagnosed myeloma is there, you will give some form of treatment. So the disease burden comes and goes to drastically to the baseline. After that, patient will be on maintenance therapy for some period of time. So over a period of time, it gets relapse. You change the therapy, then there will be remission. Again, for some period of time, the remission will be there. Again, soon relapse, and over a period of time, they will become the triple class refractory myeloma, which has a very dismal, very poor outcomes. So this is the natural history of multiple myeloma. The if you take a solid tumor counterpart which behaves in such a manner is an advanced ovarian cancer. The same thing. So in the advanced ovarian cancer, you will see similar type of graph in the solid tumors where the patient will have a huge disease burden at present. You will give paclitaxel with or without bevacizumab. It falls after some period of time. Either it becomes a platinum sensitive relapse or a platinum refractory relapse. Soon you will use some drugs, will get remission, again relapses, remission. So the similar kind of graph in the hematological malignancies will be seen with multiple myeloma. Coming to the diagnosis of myeloma, so all patients will be undergoing a bone marrow examination because you need to prove more than 10% of clonal plasma cells. Ideally, it is a bone marrow aspiration and biopsy. And in the biopsy, if you are seeing the plasma cells, it is always ideal to do an IHC or in situ hybridization and prove the clonality of the plasma cells. Thereafter, for the myeloma defining events, you need to do the calcium and the hemogram to check for the anemia and skeletal imaging to look for the bone lytic lesions and the renal function test to look for the renal failure and the elevated creatinine. Apart from that, you will do a comprehensive myeloma profile consisting of serum immunofixation, protein electrophoresis, and immunofixation free light chains, and also the beta 2 microglobulin, which helps in the risk stratification of the multiple myeloma. So these are the baseline investigations you typically do in all multiple myeloma cases. So coming to the bone imaging, so there are four different ways of doing bone imaging. One is skeletal X-ray, so which is a conventional way of doing bone imaging. So to identify the lytic lesions, so this was the first skeletal imaging which was proposed where a punched out lytic lesions were observed in the skull X-ray, either in the spine or in the long bones. Thereafter, the concept of low dose CT has came because skeletal X-ray you can't you may miss some lytic lesions and you may be underdiagnosing some cases of multiple myeloma. Later, the high sensitive techniques like FDG PET CT scan and the whole body MRI are being used. Of all, the most common, feasible, easily available test which need to be, of course, if you ask me, which need to be mandatorily done in all cases of multiple myeloma is the PET CT scan, which can significantly increase the sensitivity and specificity, and you can identify thoroughly the amount of skeletal lesions the patient have. Because there is a concept of PET based MRD assessment where various studies had shown that post induction treatment, if there is a no FDG uptake on the skeletal lytic lesions, or post transplant if there is no residual FDG uptake, so those patients tend to have a good prognosis than the patients who have a FDG uptake post induction treatment or the post transplant. So it helps in identifying the skeletal lesions. Also, it helps in identifying the extraosseous lesions. Also, it helps in prognostication upon assessing the response to treatment. So you have done a good number of investigations for the diagnosis of multiple myeloma. You've done bone imaging. Next important concept is to do the risk stratification of myeloma. So the major risk stratification of myeloma, if you ask me, it is dependent on four important factors. The one thing is the cytogenetic abnormalities, the most important. The patients who have a 414, 416, 17p and gain of 1q are considered as the high risk cytogenetic abnormalities. The second easily available test you can do to in all patients is the LDH. If any patient has at least two times of LDH than more than the upper limit of normal, is considered as an high risk myeloma. The third important treatment is the presence of an plasma cell leukemia. So you do a peripheral smear, check for the presence of plasma cells in the peripheral smear. If at all you are observing more than 5% plasma cells in the peripheral smear, it is considered as the plasma cell leukemia. It is considered as a very high risk aggressive behavior. The fourth simple test which need to be done in all patients is the beta 2 microglobulin. Elevated beta 2 microglobulin puts the patient in ISS stage 3, which is considered as having a lesser survival compared to the patients who have a normal beta 2 microglobulin. Apart from this, what is the main advantage of doing PET CT scan is to assess the extent of extramedullary involvement. Any form of extramedullary involvement is considered as a poor prognostic sign in a myeloma. And of all, the most important thing which predicts the prognosis in multiple myeloma is the response to the therapy and the maintenance of the response to the therapy. So this is the way back Salman Dury, which proposed the staging system where they used multiple factors, but we don't follow it now. So just for completion's sake, I'm telling that the first initial, the risk stratification, which is based upon the myeloma cell mass, amount of lytic lesions. So this was proposed by Salman and Dury, which was used for quite a good period of time. But later, this is the simplified staging system which was proposed for the multiple myeloma ISS staging system, international staging system, which consists of only two factors. One is albumin and beta 2 microglobulin, and it had shown that stage 3 has a very poor outcome compared to the stage 1 and 2. So this is the progression-free survival and overall survival in both transplant eligible and ineligible, and across North America and in Europe, it was shown to have a significantly the ISS stage has predicted outcomes in multiple myeloma. So this is the revised after that. For the first was the Salman Dury. After that, the ISS. Later, the concept of doing fish testing and identifying the high risk cytogenetic abnormalities were identified. Of them, the classical three cytogenetic abnormalities which constitutes worst prognosis are the presence of 17p deletion, translocation 414, and translocation 1416. So based in by incorporating this, and as I previously told the amount of LDH, so by incorporating these two, a new risk stratification model was proposed, which is called as RISS, where it significantly predicted the outcome. So if you ask me today, this is the most validated, this is the most widely used risk stratification in the myeloma. So thereafter, a revised second revision of the RISS was done, but this also included 1Q amplification, which is considered as the high risk, and they have divided the intermediate risk of high risk into two subgroups, and they had put four stages, but this is not widely used. This is so validated as of now, a very slightly cumbersome to use in the routine clinic, and it is not widely practiced. So there are four different staging systems which are evolved and developed over a period of time: Salmon Dury, ISS, RISS, and R2ISS. Of them, most widely acceptable, widely used is the RISS staging of the multiple myeloma. Coming to how frequently you observe these cytogenetic abnormalities in multiple myeloma. So previously the trisomies were tested, but they doesn't have any significance. Now nobody is testing for trisomies in multiple myeloma. So IGH translocations can be observed in 40 and 40% of the patients can be high risk at diagnosis. And this is my personal experience from NIMS. So the 24 patients have a deletion 13q and the IGH translocation and trisomy 14 were seen in 20 and 18% of the patients, and deletion 17p were observed in 10% of the patients. This is a real world data and my personal experience of approximately 167 cases from the Nizam's Institute of Medical Sciences. Coming to the treatment paradigm, so this is regarding the evaluation. So you will be doing a bone marrow aspiration biopsy along with IHC, followed by comprehensive myeloma profile consisting of LDH beta 2 microglobulin, protein electrophoresis, and immunofixation electrophoresis, and serum free light chain assay. After that, you do a routine blood workup to identify the hypercalcemia, renal function, and the anemia part. And next, the important is the skeletal imaging. So of four, preferably easy to do, uh, will give a very good amount of disease burden is the PET CT. Preferably, that is the first thing which need to be done. If at all that is not available, not able to do, low dose CT or almost skeletal radiography is obsolete. So if at all nothing is available in a very resource limited setting, if you want to do skeletal radiography can also be done. But the ideal choice would also always be a PET CT scan. Next, risk stratification by doing an LDH, beta 2 microglobulin, and the cytogenetic abnormalities. Of the four staging or risk groups, the most common thing which we follow is the RISS, which consists of using LDH, FISH, and ISS stage. These three incorporated and a revised ISS was proposed, and high risk is considered to have a worse prognosis than the intermediate and good risk people, the stage 1, stage 2, stage 3. So coming to the treatment paradigm, so as previously I told, it is a disease which consists of remissions and relapses. So the first and foremost thing for any myeloma patients sitting in front of you, the first line to be written is he is diagnosed as a multiple myeloma. He has a RISS stage. When you are writing a diagnosis and an OPD paper, so tomorrow morning when seeing a new myeloma case, so it is called as a multiple myeloma. The basic things which need to be done, which need to be there for everyone to understand it is a case of multiple myeloma. What is the RISS stage of the patient? The next thing is whether the patient is transplant eligible or ineligible, because these are and the risk stratification, high risk or standard risk, because these are the things which help you in defining the treatment, defining the protocol of the patient, and also defining the prognosis of the patient. The first algorithm, so the first thing which need to be determined is whether the patient is transplant eligible or ineligible. So what defines the transplant eligibility? It differs from institute to institute and expertise of the physician who is doing transplants and the age cutoff. Some will keep 60 as the age cutoff for doing transplant. Some will keep it as 65. Some will be doing for patients more than 65 who are fit and able to undergo the procedure of stem cell transplant. But in my routine practice, I typically do for all cases which are less than 65 and which have a good organ reserve and who are able to undergo and tolerate the procedure of stem cell transplant. And more than 65, I usually tend not to do a transplant unless he is extremely fit enough to undergo a process of stem cell transplantation. So whether the patient undergoes a stem cell transplantation or not, there are three blocks of treatment in multiple myeloma. One is called as the induction treatment, which consists of the first 4 months of treatment. Consolidation in a transplant eligible patient, transplant is considered as the consolidation. For a transplant ineligible patient, 5 more cycles of the same chemotherapy in responders is considered as the consolidation. After that, both in the transplant eligible and the ineligible patient, all the patient will be receiving maintenance therapy till the relapse. Coming to the what are the various concepts of important issues to be discussed in choosing the frontline therapy. So we know that triplet has become a standard of care in the management of multiple myeloma. When I was doing residency in 2013 and 14, so doublet was used where bortezomib and dexamethasone was used as the doublet, or lenalidomide and dexamethasone combination was used as a doublet for India. Over a period of time, we have a very good strong data and decent data to say that triplets are the way to go in multiple myeloma, and we have been using the triplets for a quite a very good period of time. We observed very good responses. Almost we have given very good survivals for a decent number of patients. Upon the arrival of the anti-CD38 monoclonal antibodies, the concept of quadruplet induction has came into the picture, and now there is a debate still going on, triplet versus quadruplet used in the management of initial treatment of myeloma. But we had a decent data in the recent times to say that quadruplet is the way to go in multiple myeloma, especially in the high risk groups, because they are tend to have a very poor survivals, very aggressive behavior of the disease, and treating with a quadruplet is the ideal way to go, especially in the high risk disease. Next matter of debate is whether we are be doing a frontline or a delayed transplant, and if you are doing a transplant, whether to do a tandem transplant or not. This is the matter of debate. So we'll be seeing what the data says. Next, if at all, if there is a high risk disease, any aggressive strategies are needed, and what is the concept of maintenance in the management of myeloma? If you ask me what are the landmark triplet trials by which you suggest that triplet is the standard of care, this is the first trial of SWOG where lenalidomide dexamethasone was compared with bortezomib, lenalidomide, and dexamethasone. And in a nutshell, briefly, I am telling that the response rates are good with triplet, the progression-free survival is improved with triplet, and overall survival was significantly better with the triplet. So upon publishing of these results and these trial data, VRD has become the standard of care in the management of multiple myeloma. So there is no doubt, there is no debate for that. Triplet is the way to go. Triplet is the standard of care in the management of multiple myeloma. Another triplet which was tried is the DARA RD versus RD, especially in transplant ineligible myeloma. Transplant ineligible myeloma. So, hello. So, in transplant ineligible myeloma, so compared to the RD, DARA VRD had shown to have improved progression-free survival rate, improved response rate. But there is a criticism for this trial is that DRD was not compared with VRD because VRD is the standard of care in the multiple myeloma. If DRD has been compared against the VRD and had, if it had shown to have benefit, definitely DRD has become should have become the standard of care, especially in transplant ineligible patients. But this has been not compared with the VRD. And but if you want to omit the bortezomib based regimen and use a triplet, we have a data to use DRD, and this is the trial which had shown DRD improves survival compared to the RD. Next, other triplet regimens we commonly use are the BTD and VCD. So VCD are also called as the CyBOD regimen, which we traditionally called it as a CyBOD. We know that 20 to 30% of the patients will present with renal failure, significant renal dysfunction, where we are not able to use lenalidomide. So in those patients, we have two options of using either the thalidomide, either the cyclophosphamide replacing the lenalidomide. Because bortezomib and dexamethasone doesn't need any renal modification. So only thing which we omit is the lenalidomide. So we can replace it with VTD, the thalidomide or cyclophosphamide. This is the IFM trial from the IFM group where VTD was compared with VCD and shown that both are almost equal. Apart from there was a slight better response rates with the VTD compared to the VCD, but the overall outcomes are similar. The only problem with the VTD regimen is both bortezomib and thalidomide can cause a significant neuropathy. So upon using of 4 to 5 cycles, a significant number of patients can have a neuropathy compared with VCD regimen. So because of this, majority of the times, if the triplet is being used, it is VRD. If we are unable to use VRD, the other regimen we typically use in our practice is the VCD rather than the VTD. Because if at all there are cytopenias where you can't use cyclophosphamide, then you can use thalidomide. Otherwise, the two regimens commonly used in day-to-day practice is either VRD for patients without renal dysfunction, VCD, or also called as CyBOD in patients with significant renal dysfunction. So RVD has been the standard of care. there was a trial to replace bortezomib with carfilzomib, but there is no difference. The endurance trial. So first line VRD is the standard of care. So this has shown that triplet is the way to go. So there is no much debate in using the triplet. Now came the concept of quadruplets. This is the Perseus trial. So the randomized phase 3 trial in transplant eligible patients with newly diagnosed multiple myeloma, where DARA VRD was compared with VRD, followed by consolidation and maintenance. And in transplant eligible patients, those patients underwent a autologous stem cell transplantation. This has shown that the 4-year PFS was improved significantly by almost 17%, and the response rates, either the complete remission rates, stringent complete remission rates, or the MRD negative rates, or the sustained MRD negative rates were significantly better with the DARA VRD combination compared to the VRD. And this trial has concluded that this is the way to go in the multiple myeloma, where the DARA VRD combination improved progression-free survivals, improved CR rates, improved MRD rates, and a quite safe drug, which was comparable to the VRD. So this has almost ended the debate whether to need to use a quadruplet or a triplet. And now almost all in all cases, quadruplet is the way to go, especially if you want to use in a selected group of patients quadruplet. High risk patient is an ideal patient to use a DARA VRD combination. And another monoclonal antibody, so like daratumab, it is called isatuximab, the same mechanism, same drug from a different company. So it isatuximab plus VRD. So this is the trial which was done in transplant ineligible patients, IMROSE trial, where isatuximab VRD was compared with VRD, and it was shown to have improved progression-free survival rates, the similar findings of improved overall response rates, complete remission rates, and also the improved progression-free survival and the MRD rate. So but the OS data is mature at 5-year analysis. So this also shown that there was improved sustained MRD rates, CR rates, progression-free survival with quite good, decent quality of life and tolerability profile. And these both trials had shown that quadruplet is the way to go. Either the DARA VRD or the isatuximab VRD is the way to go. There are two other trials. I am not discussing much about the Griffin trial because this is only a phase 2 trial. But we have a very other big trial called Cassiopeia trial. So which is called as the phase 3 randomized trial of using VTD as backbone, because still in Europe, lenalidomide is costly and majority of the times VTD is the backbone which they commonly use. In this trial, DARA VTD was compared with the VTD, and it had shown to have a good remission rates and outcomes. So DARA VTD is another regimen need to go, especially when you are not able to use lenalidomide in patients with renal failure. So this is a phase 2 trial. I'm not going to much details of this trial. This is the Griffin trial, where the same findings of the Perseus trial, the DARA VRD, the 4-year progression-free survival rates were improved by 17% with the DARA VRD compared to the VRD. But what are the problems with this anti-CD38? Or there is increased risk of infectious complications. So all patients should receive herpes zoster prophylaxis. Hypogammaglobulinemia may occur, and they may affect the vaccine efficacy. And of all important is they disrupt the Coombs test. Therefore, the patient's blood group typing and screening to be and cross-matching need to be done prior to the infusion of the drug. And they can cause infusion-related reactions. Appropriate pre-medications to be given, especially the use of Montelukast before the daratumab doses has significantly reduced the infusion reactions. I personally experienced in my professional life that use of Montelukast has significantly and dramatically reduced the infusional reactions which were associated with the daratumab. But with the availability of the subcutaneous daratumab now in India, so we may not be seeing much of infusion reactions. So I hope I'm clear till now that we have the data to say that triplet is a standard of care. Now, in the last 2, 3 years, there is published data to say that quadruplet is the standard of care. So in those trials, all patients benefited with the quadruplet. But in a resource limited country like India, where if you want to use in for a limited group of patients, it is always the high risk group patient, especially the patients who are 17p and 414 translocation patients, or the patient who need a quadruplet induction. And both the trials of IMROSE and the Perseus had shown that improved complete remission rates, improved MRD, sustained MRD rates, and improved progression-free survival with the use of quadruplet therapy compared to the triplet therapy. Next come the significant, so the first point of debate is almost over. So quadruplet is the way to go because we had a data from phase 3 trials. The next matter of debate is you doing an upfront autologous stem cell transplantation, still the standard of care. So we have answers from two major trials. One is the IFM trial. So this is the first trial, VRD plus transplant, followed by early versus delayed transplant. So this is you all the residents who are listening this class should remember that all these trials are not for all these trials the point of discussion is not doing transplant versus transplant. It is the point of discussion whether to do a transplant early or delayed. So in countries where the resources are not limited, up post VRD 3 to 4 cycles, they will collect the stem cells, they will preserve it, and they will do transplant at the time of relapse. But in a country like India, where the resources are limited, it may not be possible, it may be not cost effective to mobilize the stem cells to cryopreserve and to do it relapse. And if you ask my personal opinion, for all transplant eligible patients, majority of the patients in the Indian context are not eligible or not affordable for daratumab or isatuximab based therapies. So if you ask me, all transplant eligible patients should undergo an early stem cell transplant in their natural course of the disease rather than the delayed transplant. But from the phase 3 data, we have a data to say that delayed transplant also does well. So this is from the IFM where the delayed transplant giving a equal overall survival compared to the early transplant. But only difference was the progression-free survival was better with the early transplant. The same happened with the determination trends. Similarly designed trial, there was no difference in the overall survival, but the progression-free survival was better with the early transplant. But all these trials, it need to be remembered that 70 to 80% of the patients underwent autologous stem cell transplantation at the time of relapse. So you need to think in a practice whether you will be able to do transplant at relapse or not, and to take a call on the early versus delayed transplant. In my routine practice, I will counsel all my patients for an early transplant and will try to do the transplant after initial 4 cycles of chemotherapy in all transplant eligible patients. So the high risk patients benefited significantly better than the standard risk patients with the transplant. So if you want to do a delayed transplant, it need to be done only in the standard risk patients. It not, but all patients with high risk myeloma need to undergo a early transplant compared to the delayed transplant. So coming to a short trial on the tandem transplant, tandem is you are doing a back-to-back transplant. So upon the availability of these daratumab-based therapies, nobody using tandem transplant, but there is a small data to say that tandem transplant can be done, but there is only this is small data. So nobody is nowadays doing this tandem transplant. But if you want to do a tandem transplant, so only patient who may benefit with doing tandem transplant is the patient who had a 17p mutation, who is not affordable for daratumab, and who had a less than VGPR after initial 4 cycles of therapy. If you have a patient who is having a 17p deletion or a high risk myeloma, who is not affordable for daratumab, who has a less than or equal to VGPR after initial induction chemotherapy, then that is the patient who may benefit by doing a tandem transplant. Otherwise, tandem transplant is almost obsolete in the management of multiple myeloma. Coming to the third important concept, so of maintenance therapy. So this is the trial which had shown that lenalidomide maintenance post induction transplant had significantly improved the progression-free survival and overall survival. And this is the exosomic maintenance which had similar findings. And this is the Cassiopeia trial where DARA maintenance was used and to have shown to have similar benefits of improved progression-free survival. So upon these trials, some form of maintenance therapy is needed because all these trials have significantly improved the progression-free survival and overall survival in multiple myeloma. So a small take home from the Cassiopeia trial. In Cassiopeia trial, there are 4 arms in which the patients who received initial daratumab, if you continue daratumab in the maintenance, they didn't get benefit. But in the patients who didn't receive daratumab, if they have received daratumab in the maintenance, they got benefit. So if you have used daratumab during the first 4 cycles of chemotherapy, Even if you don't use daratumab in the maintenance, it is okay for the patient. So you can counsel that if I use daratumab, get a good response, I can omit using daratumab in the maintenance, because Cassiopeia trial has shown that if I use daratumab in the induction, there is no much added benefit of continuing the daratumab in the maintenance therapy. But if you have not used daratumab in the initial induction and by some means patient is able to procure daratumab post transplant, you can add maintenance, because the arm had shown significant benefit compared to not using the daratumab. So this is the for the transplant ineligible patients. So always use the triplet. Always use adjusted lenalidomide dose based on the creatinine clearance, because all the transplant ineligible patients may not tolerate the full doses. There is a beautiful regimen called VRD light where we will be using the smaller amounts of doses. In Indian context, especially the patients who are transplant ineligible, elderly, frail, I start with VRD light and will assess the tolerability and will escalate the doses from the second and third cycles of chemotherapy. So this is another trial of Alcyone in transplant ineligible patients where DARA VMP showed significant benefit compared to the VMP. And if at all you are not able to use a IMID based therapy because of some reason, so this is the regimen you can use DARA VMP, which had shown significant benefit. So this is regarding what chemotherapy part in the multiple myeloma for either the transplant eligible patients or the ineligible patients. Either the triplet or the quadruplet is the standard of care, but all high risk patients, it is always ideal to give a quadruplet induction. Ideal is to do an early transplant, especially if the patient is high risk. And maintenance therapy, there is a data to say that 2 or 3 years of maintenance is fine. But in my routine practice, I will use maintenance till progression or toxicity in the management of multiple myeloma. So there is a small data to say that doublet maintenance can be used in high risk myeloma. Doublet is using both bortezomib and lenalidomide. I started practicing using since last year. If at all you have a high risk myeloma, you can consider using a doublet maintenance also. But single agent is also okay. But high risk myeloma, you use bortezomib maintenance. For a standard risk, use a lenalidomide maintenance. So keeping this chemotherapy apart, so one of the significant cause of mortality and morbidity in patients with multiple myeloma is these three things: the thromboembolic events, the infection, and the bone health. These three components to be taken thoroughly into your mind, and to educate the patient that these, rather than the chemotherapy, rather than the disease, these are the things which is going to impair the significant quality of life, also can cause morbidity and mortality in the multiple myeloma patients. So at diagnosis, all patients of multiple myeloma should be thoroughly educated about the thromboembolic events, because they may be receiving IMIDs which can cause significant risk of thromboembolic event. So all patients should be on either the low dose aspirin prophylaxis. If they have a higher risk of having a thromboembolic event, they should be on either the low molecular heparin or some newer anticoagulants. You should educate the patients on preventive strategies and early detection. Coming to the infection risk, multiple myeloma as such is an immunosuppressive state. The use of monoclonal antibodies and the treatments can significantly cause hypogammaglobulinemia. They have a high chance of having infections. So appropriate vaccination to be given. The most common significant infection we see is the herpes zoster infection, because both bortezomib and daratumab has significantly increased the risk of having herpes zoster. All patients on these therapies should be on acyclovir prophylaxis. If at all the patient has an hypoglobulinemia causing recurrent life-threatening infections, the patient should be receiving IV immunoglobulin. So bone health is important because all patients will have a lytic lesions. Any fracture can significantly impair their quality of life. So either the bisphosphonates or the denosumab should be given, and their bone health precautions need to be taken. Coming to a small role on the MRD. So we will not be doing much of MRD in our routine practice, but trials had shown that MRD attainment will significantly improve the outcomes compared to the patient doesn't attain the MRD. So coming to the treatment of concluding the newly diagnosed treatment of myeloma. So for standard risk or high risk, as I told you, quadruplet induction, either the DARA VRD or isatuximab VRD. preferably do an early autologous stem cell transplant. But for a standard risk patients, if you are able to cryopreserve stem cells, so cryopreserve them. You may get a doubt that why I need to cryopreserve the stem cells. You can collect the stem cells at the time of transplant. But the use of daratumab for a prolonged period of time, use of a lenalidomide for a prolonged period of time, impair the amount of and the quality of stem cells we get. So it is always ideal if you are planning for a delayed transplant, you should always collect the stem cells, cryopreserve them, and only continue either the daratumab or the lenalidomide. So you continue it for either next 4 to 8 cycles, followed by maintenance. All patients of high risk post-transplant should be on a doublet maintenance, as I previously told you, that is bortezomib plus lenalidomide maintenance. For patients who are transplant ineligible, so it can be a triplet, either the VRD or DRD, or quadruplet like DARA VRD or isatuximab VRD. You can use it for 8 to 12 cycles. So I will be telling to all my colleagues and juniors regularly that so you should not stop the treatment at 4 cycles and switch on to maintenance. If you are not doing a transplant, you continue the triplet or quadruplet regimen for at least 8 to 9 cycles. I preferably tend to do it for 1 year of therapy because you need to deepen the response so that the maintenance will be taking care for a good period of time. If you stop the treatment at 4 cycles, start on the maintenance therapy, the patient will be relapsing soon because if your depth of response is good, your relapses will be delayed or significantly at a later period of time. So don't give 4 cycles and jump onto maintenance if you are not doing a autologous stem cell transplantation. If you are doing an autologous stem cell transplantation, fine, straight away start maintenance therapy. If you are not doing an autologous, because I have been seeing quite a number of good period of time, many are jumping to a maintenance after getting a response after 4 cycles of therapy. But it is not always ideal to start maintenance therapy after 4 cycles. Your response assessment should be after 4 cycles, but your maintenance should start after at least 8 to 9 cycles. That is 8 to 9 months of therapy. You deepen the response as soon as much as possible, and then only switch to the maintenance therapy. Coming to the relapsed myeloma, as I previously told, so the relapses are much common in myeloma. So you categorize them into 3 categories: a relapsed multiple myeloma, relapsed refractory multiple myeloma, or primary refractory myeloma. So what is the difference is, if you got a response, if the patient has got a response, after that the disease came back, it is called relapsed myeloma. If the disease comes back within 60 days of time, it is called as relapsed or refractory myeloma. You have never achieved at least a minimal response with any therapy, it is called as a primary refractory myeloma. So, what are the primary goals of treatment? Achieving a response, relieving the disease symptoms, prevent new organ damage, and achieve a long lasting disease remission. So, these are all the important things which help in choosing a treatment for relapsed myeloma. So, patient characteristics like age, frailty, performance status, disease burden, biology of the disease, and the toxicities from the previous treatment, affordability of the patient. Based upon that, what was the initial regimen which was used? So these are the things which we take into counter to choose a most effective regimen with good safety and which maintains the quality of life. Coming to data per se, this is the lenalidomide-based regimens: carfilzomib, lenalidomide, dexa, daratumab, lenalidomide, dexa from Pollux trial, ixazomib, lenalidomide, dexa from Tourmaline trial, elotuzumab, lenalidomide, dexa from Eloquent trial. So all these trials had shown that in relapsed myeloma, addition of carfilzomib or daratumab or ixazomib or elotuzumab significantly improves the progression-free survival compared to the doublet. So we are now have a decent data show that triplets are the way to go. Either the carfilzomib, daratumab, ixazomib, or elotuzumab based lendexa. And we also have a PI based combinations where carfilzomib was tried in Endeavor, Dara VRD, Dara bortezomib dexa in Castor trial, pomalidomide, Velcade dexa in Optimism trial, daratumab, carfilzomib dexa in Candor trial, and isatuximab, carfilzomib trial, IKEMA trial. So all these trials had shown that the triplet is the way. The previous slide was lenalidomide based regimens. These are the PI based combinations where triplet combination is the way to go, which significantly improves the progression-free survival and the overall survival. So how to choose? So no one size fits all. So it all depends upon what is the sensitivity to the previous treatment, what is the primary treatment patient has received, on which maintenance patient has relapsed. Based upon this, you choose the therapy. So the only drug which is quite significantly effective in your day-to-day practice, if you have not used in the frontline treatment, is the daratumumab. So if the patient doesn't receive daratumumab-based therapy in the frontline, the only drug which has significantly shown across all trials and the only drug which need to be mandatorily used in a relapse setting to improve the survival is the daratumumab-based therapies. So these are all I have already discussed all these trials, and this is the pomalidomide based trials, all shown to have significantly improved trials. And this is a gist of all the trials of phase 3 trials in the management of multiple myeloma. So all triplet trials. And this is the recent from the recent paper published by Vincent Rajkumar. If the patient is not refractory to lenalidomide, so you can use Dara Lendexa. So Dara should be the drug which you're going to add. If the patient has already received daratumumab, and you can use a KRD regimen, carfilzomib lendexa, or isatuximab or ixazomib lendexa, or elotuzumab lendexa. So one thing you need to remember is if the patient is DARA refractory, he is also refractory to isatuximab. There is no role of using isatuximab post-DARA. Both are quite similar molecules. So one CD138 refractory molecule, so it is also refractory to the another CD38 molecule. So if patient is not exposed to DARA, RD is the goal. If the patient has exposed to DARA, then KRD is the way to go. If the patient is refractory to lenalidomide, so daratumumab, carfilzomib, or daratumumab, pomalidomide dexa, or if the patient has previously received daratumumab, so carfilzomib based or pomalidomide based regimens can be tried. So choosing the third line, it all depends on what the frontline therapy patient has received, what second line therapy patient has received. So by these two things, you can choose the third line therapy. But in patients who has relapsed, as I told you, clinical pearls, significant things which you need to know is the carfilzomib resistance is equal to bortezomib. So bortezomib and ixazomib won't work if already the patient has exposed to carfilzomib and has progressed. If the patient has already progressed on pomalidomide, lenalidomide won't work. So daratumumab resistance is equal to isatuximab resistance is known now. As of now, there is no cross-trial comparisons, but as of now, we have a decent data to show that no role of isatuximab post daratumumab or no role of dara post isatuximab. Both are quite a significant similar molecules. So if refractory to one is refractory to other also. So this is how you choose myeloma treatments in the second line and third line therapies. And coming to the last segment on immunotherapy, we know that immunotherapy has significantly changed the way in the solid tumors. Now, immunotherapy has also changed the way in the multiple myeloma. We have antibody drug conjugates like belantamab. We have BCMA directed CAR T cell therapy like ida-cel and cilta-cel. We have bispecific antibodies which are available for the treatment of multiple myeloma. These are the various bispecific monoclonal antibodies like erlantamab, teclistamab, talquetamab, and cevostamab. So all have shown significant overall response rates, but quite a good number of patients can have infection on these drugs, and the patient and the doctor who is giving these drugs should be vigilant on getting the and treating the infection at the earliest point of time. But once the patient has received 2 or 3 lines, these are the drugs which had shown significant response rates and survivals, the bispecifics of them. So none are available in India as of now, but Johnson and Johnson is going to launch teclistamab soon in India. But there are 4 monoclonal bispecific antibodies: erlantamab, teclistamab, talquetamab, and cevostamab. And 2 CAR-T trials had also shown benefit. One is the KARMA trial, and another is the CARTITUDE trial. One is ida-cel and cilta-cel, which both had shown to have good response rates and survivals with the use of these trials in the relapsed refractory multiple myeloma. But in India, we don't have availability of these trials. We need to import from them. And we have an indigenous Indian-made CAR-T for directed against BCMA is being developed and will be soon be tested in Indian patients, will may be available next year soon. These are all the CAR T cell therapy which we have now and which are in the pipeline. So these are all the randomized phase 3 trials of Karma, Cartitude, Dream 3, Dream 7, and Dream 8 of bispecifics, and also the CAR T cell therapies. And the last drug which had shown and used in relapsed myeloma is venetoclax. We all have been using vigorously in the management of AMLs, but this is the Bellini trial where venetoclax was tried in multiple myeloma, but only patients who got benefit was the patients with 11-14 translocation. So if you have any patient of 11-14 translocation who has a relapsed refractory disease, venetoclax is the drug which can be used, which can be tried either as a single agent or along with the combination of venetoclax and dexamethasone, which can get good responses and survivals in 11-14 translocated myeloma. So we had seen how we diagnose myeloma, frontline management of myeloma, how we uh, manage a relapsed myeloma in the second and third lines, and the role of immunotherapy, the bispecific, and the CAR T cells in the management of multiple myeloma. To conclude, so I have already discussed this slide of managing the transplant eligible and ineligible. Quadruplet is the way to go in the initial treatment. If not able to use a quadruplet, triplet is a very decent option. So based upon the initial regimen and refractoriness to the lenalidomide or bortezomib, you choose the subsequent therapies. In the later lines, either the CAR T cell therapy or the bispecific monoclonal antibodies are the way to go. And choosing third line depends upon what the treatment of first line and patient second line the patient has received. Thank you.
Dr. Stalin, excellent class, starting from the pathogens to CAR T cell and white cells. So there were some questions in the chat box. Uh, it was, so there is a question that isn't gain and amplification both different things for a 1Q, and it's only 1Q amplification included in a poor prognosis class.
Yes, it is the 1Q gain 1Q amplification was which was included. Or how long we give prophylaxis? What prophylaxis? I didn't know. So for example, for a patient who has an who is on Dara and bortezomib, as long as they are on Dara and bortezomib, they need to give acyclovir prophylaxis. So regarding the antibiotic prophylaxis, there was a much debate on whether to use the levofloxacin prophylaxis or not. So some physicians practice using a levofloxacin antibacterial prophylaxis, some don't. There is a data to say that levofloxacin prophylaxis works, but in a country where like India, where levofloxacin was rampantly used and many organisms are resistant to a levofloxacin, I don't think levofloxacin prophylaxis will work in the management of multiple myeloma. When plasma cell leukemia present without a uh, bone bone lesion, yes, it can present a bone lesion because at diagnosis, bone lesions either in the multiple myeloma or in the plasma cell leukemia, they can be seen only in 60 to 70% of patients. In my experience, also 30% of the patients present without any significant bone lesions. They can have either hypercalcemia, anemia, or FLC ratio of more than 100. So they don't have any skeletal lesions. What about anticoagulation? In general, if the patient doesn't have a high risk for thromboembolic events, ecosprin 75 mg once a day is fine with lenalidomide. If the patient has a high risk, definitely newer anticoagulants need to be used. Either the low molecular weight heparin or the newer oral anticoagulants like rivaroxaban or apixaban can be used as an thromboprophylaxis. Can we give levofloxacin? Yes, if it is institutional practice. Previously, I used to give. Now I have stopped giving levofloxacin prophylaxis. The major part to be concentrated on giving the vaccination part, annual flu vaccine, and also the pneumococcal vaccine if the patient has not received it. And especially with the availability of Shingrix vaccine, you can consider giving a Shingrix vaccine also in patients because these are the patients who had a highest chance of having a herpes zoster infection. So it will be Though it may not be a life-threatening infection, but it can significantly impair the quality of life of the patient. For renal deranged patients, how to salvage the kidney? So you can get renal reversibility in 50% of the patients, definitely. So in my practice also, I have observed. So start treatment as early as possible. Initial, you can do plasmapheresis also, but I have never done that. Start treatment as soon as possible. You can use, especially if the patient is affordable, DARA-based regimens can reduce the disease burden significantly and can help in getting a good renal reversibility. But even with the bortezomib-based regimens, we had seen that renal reversibility can happen in 40 to 50% of patients. High flux HD, I am not doing it in any of my patients. How to decide maintenance therapy post transplant? It is predominantly based on the risk stratification, based on the MRD. Still, we are not adopted and not practicing it. So it is based on the risk stratification. If it is a standard risk, lenalidomide maintenance is fine. If it is a high risk, if you want to use a single agent, it is always bortezomib maintenance. But ideally, I am practicing giving bortezomib and lenalidomide. That is the doublet maintenance. Is plasma cell leukemia treated like multiple myeloma? As of now, today, yes. But if the disease burden is high, an aggressive regimen like VTD PACE can be given, which incorporates the VTD regimen along with some chemotherapy drugs if the disease burden is very high. But if you are able to use daratumab, so dara-VRD is a decent regimen to be used. Zolidronic frequency for the 6 to 8 months, I will be using it monthly once. After that, you can decently use it 3 monthly once. Dosing, it depends upon the renal compromise. Ideally, it is 4 mg. If there is a renal compromise, you can reduce it to 3. In severe renal failure, where the creatinine clearance is quite low, you can't use it. You need to use denosumab. How long to give it maintenance? 3 years is the minimum period where you practice maintenance, giving maintenance. But in my practice, I typically give it till progression or toxicity. There are two schools of thought. So you can give it till progression or toxicity, or you can give it 3 years and stop for a patient who can you can closely monitor it. But my practice is to give till progression of toxicity. Is there a role of PET-CT in response assessment? Yes, as previously I told you, PET-based MRD assessment is also there. You can assess MRD, the FDG uptake post induction and post transplant, and it was shown that, and a study done by Uday from India also shown that PET negativity after transplant has significantly good prognosis than PET positivity. Role of Septron prophylaxis, as of now, while we are using a low dose dexamethasone, the low dose is 40 mg weekly. There is no much role of Septron prophylaxis. But previously, when the high dose dexamethasone was used, where 4 days on, 4 days off dexamethasone was used, then if you are using such a regimen, but that is completely obsolete now, there is no role of using a regimen like that. If you are using, when that regimen was used, Septron prophylaxis was used. Role of MRD, ideally you can assess. It helps in prognostication, but as of now, you don't make any treatment decisions based upon the MRD. Any difference of maintenance duration based on HSCT? No. For a patient who doesn't undergo a transplant, definitely it is always still progression or toxicity. The duration of maintenance concept, I'm talking only patients who are transplant eligible and who underwent transplant. Role of bisphosphonates in multiple myeloma without bone lytic lesions, we used to give, but typically I'm not giving now. So transplant ineligible, how to choose between 3 or 4 drugs regimens? So preferably, so if you ask me in my practice for a transplant ineligible patient, it all depends on again the risk stratification. So if even if a transplant ineligible patient is there with a 17p or a 414 translocation, and if patient is affordable for a DARA, I use a DARA VRD based regimen. But the VRD component will always be VRD light in the initial, where we're using 10 mg of lenalidomide and lesser amount of dexamethasone of 20 mg. So, but if the patient is not affordable for daratumab, VRD is a decent triplet regimen. Dose of len used in maintenance is 10 mg. So, but 20 to 30% of patients may not be able to tolerate even 10 mg of lenalidomide post transplant, so you'll be using only 5 mg of maintenance in that. Any center in India offering CAR T cell therapy, you need to import the product from the foreign to do it. So many centers are doing CAR T cell therapy, they can do it, but there is no product available as such in India. So there is a phase in Bangalore St. John's with Professor Harimenan. There was a trial of multiple myeloma where he is doing CAR T cell therapy. Bed schedule of VRD, I'll be using it 3 by 4 weeks. Uh, so that is weekly once of bortezomib and 21 days of lenalidomide followed by dexamethasone weekly once. 15811 typically I don't use unless the patient has a renal failure. So where you need to reduce the disease burden as soon as possible. In those patients only, I typically use 14811 of bortezomib. Otherwise, if the patient doesn't have a significant renal failure, so I typically use it weekly basis. When to do bone marrow during follow-up, ideally may not be needed, especially for transplant ineligible patients, because serological response well correlates with the bone marrow response. But I tend to do for all transplant eligible patients before going for transplant, I do a bone marrow evaluation. CAR-T side effects, same side effects. So the neurotoxicity, ICANS, and the cytokine release syndrome. How frequent response assessment to be done during induction? Ideally, in all trials, it was every 2 cycles, but in my practice, I don't do till fourth cycle. But if the patient has a significant disease burden initially, I will check it at the end of 2 cycles. Otherwise, in majority of the patients, I will do it at the end of the fourth cycle. Next are 20 versus 40. For a transplant eligible patient, young fit patient, it is always 40. For a patient who is transplant eligible, elderly frail patients, 20 is fine. How to schedule drugs for ESRD patients on hemodialysis, preferably immediately after the dialysis, because it will be 3 weekly thrice or weekly twice. Preferably, you tend to give it immediately after the dialysis. Nara, you don't have a problem now. If you want to give it, you can give it subcutaneous. So immediately after the uh, dialysis, you can give a subcutaneous dose of Dara. Dexa in diabetics, so preferably it depends on how well controlled the diabetes in those patients be. So if it is a well controlled diabetes, 40 is fine, but poorly controlled diabetes and a poor compliant patients, I typically start with 20 and check the levels of sugars he is attaining and then can increase the dose of dexamethasone. Dara interface with SS. So for that only, there was a new technique of assessing called mass spectrometry, but it is not widely available. By mass spectroscopy, you can definitely do the SS. Otherwise, if you are doing a routine serum protein electrophoresis and the immunofixation, definitely it is DARA will cause interference in the SS. Is urine immunofixation necessary in the initial workup? It is necessary, but typically I'm not doing because of logistic reasons in my practice. But all patients of multiple myeloma need to be checked for the protein excretion in the urine because some patients can have a amyloid deposition in the kidney and can present with a nephrotic range of proteinuria too. So at least a urine protein excretion need to be amount analysis need to be done in those patients. After how many abnormal readings of immunoglobulin levels and serum free reaction ratio relapse should be considered and regimen should be changed? It all depends on how frequently you are following up with the patient and how what is the if at all the previously the patient had a FLC ratio of 3 and now you have a FLC ratio of 20 to 25. So you do not wait for further progression of the disease. You can change that at that point of time. If your previous FLC ratio is 3 and now it has been 5 and there are no other signs, you can wait for another 2 months and do a free lead chain assay. Interval of follow-up imaging. Typically, I don't frequently do follow-up imagings. So I will do only at either at the end of induction or after the transplant to check for the response evaluation. Otherwise, I don't routinely do follow-up imaging. DARA VCD for a patient on dialysis, a decent option, but there is no data of using that regimen of DARA VCD. We had a data from Cassiopeia to use DARA VTD. You can use that, but it is not wrong to use DARA VCD also. You can definitely use DARA VCD too. Practical tips to treat neuropathy. So neuropathy can happen because of the two reasons. One is because of the disease per se itself, myeloma. So all patients of multiple myeloma at baseline to check should be checked for the neuropathy, whether they have a baseline neuropathy. Second thing, with the help of drugs. So you traditionally treat them how you treat a neuropathy. But if the neuropathy is quite symptomatic, you need to omit those drugs, especially because they will significantly impair the quality of life. Only tip is preferably avoid combining bortezomib and thalidomide, so that combination is going to cause a severe neuropathy. 24 urinary protein, do it at baseline to check for the amount of, otherwise routinely not done. Do patient continue to have raised creatinine after treatment? How to do? Yes, if the patient have a initial creatinine, have a raised creatinine for a significant before getting the response. But if you are treating with a carfilzomib based treatment, carfilzomib is the drug which can significantly increase the creatinine levels. It is all depends on the drug you are using. Or remaining drugs doesn't increase the creatinine, but carfilzomib is going to increase your creatinine. How to go about patients in PR after induction? So there is no specific guideline how to do PR. So if it is a transplant eligible patients, you can straight away go with transplant, because transplant is indicated in patients who are having at least partial response to therapy. But if you want to deepen the response and do a transplant, you can try changing the regimen for 2 more cycles. For example, if the patient has been on VRD, you can change it to KPD, or you can add DARA to that for 2 cycles and deepen the response and to get. But practically, for all patients who are at least in PR, can undergo straight away transplant. These are the patients, especially if they have a high risk background in PR. These are the patients who may benefit from receiving tandem transplant, especially if they are young fit. But if you are giving a DARA-based regimen in them, so there is no much role of getting a tandem. Transplant eligible, not willing for transplant, definitely go ahead and treat like a transplant eligible patients. Give at least 12 months of triplet followed by maintenance therapy. Your thought on giving bortezomib maintenance 2 weekly and should dexa? No, there is no dexamethasone in the maintenance. If you are using it as it is a bortezomib based therapy, or either a lenalidomide or a combination of bortezomib and lenalidomide, there is no role of adding dexamethasone in the maintenance therapy. Biochemical relapse, it all depends on how bad the biochemical relapse is. As previously I told, if it is a biochemical relapse, the serum free ligatures has jumped over to hundreds and thousands, then you need to change the treatment. If it is a small variation in the, you can closely observe them. Difference in maintenance post-transplant till how long to be continued depending on the risk. Definitely. So as previously I told is it is 2 to 3 years of maintenance, 3 years ideal. Post that it is up to the call of the physician to continue the maintenance. In my practice, I typically give it till progression or toxicity. But how long DARA maintenance should be given? If not given during induction, it is still progression or toxicity as given in the Cassiopeia drive. I'll be sharing my PPT in the group, so YMO group. If you have any further doubts, then I can answer over there, or you can personally message me. I'll be happy to answer those questions. Reappearance of M-band is relapse.
Excellent class, Dr. Stalin. Very, very comprehensive. Thank you so much. I think, as far as the students are concerned, I think that your class and your slides would be good enough to for them to prepare very well for the exams also, in case, apart from the practical implications. So once you share the presentations, or you can share it directly in the YMO group.
Yeah,
And
I will share it in the YMO.
yeah, on behalf of everyone, I thank you again. We'll have further classes from you, Dr. Stalin, maybe
Sure,
later
Sujit.
this year.
Thank you for this
Thank you so
opportunity.
much,
Yeah,
Stalin. Yeah.
thank you.
Good night, everyone. Thank you
Good
so
night,
much.
everyone. Thank you. Thank you.